Welcome to the State of Health. I'm your host, Karen Bowling, Cabinet Secretary for the West Virginia Department of Health and Human Resources. If you see a lot of pink in your community during the month of October, it's because October is National Breast Cancer Awareness Month. Today, we'll talk with two medical experts about the advances made in this area and what women need to know. Plus, we'll talk to a two-time breast cancer survivor and later, the mother of a child who was diagnosed with cancer. I'd like to begin by introducing our first guest, Dr. Jim Frame, Medical Director of the CAMC Cancer Center in Charleston, and Dr. Roberto Kusminsky, Medical Director of CAMC's Breast Cancer. Welcome. Thank you so much for being here.
Thank you very much.
Thank you for having us.
You know, I wanted to start talking about what I think is the thing that women most often ask about, and that's mammography and mammograms. Can you talk a little bit about the reason we do them and the importance of them, but as well as some of the things that women need to know about mammography?
Well, mammography, of course, is a test that has been evaluated over many years, as you know. And there are several elements that are very important about it. The first part of that has to do with your question, which is, what is a mammogram for? Most people do not know what a mammogram is for. And a mammogram is simply used to detect findings that you do not detect during a regular clinical exam. So that means that we're following the holy grail of early diagnosis. We find something early, we can take care of the patient much better. That's one important element of mammography. The second one is that mammography has been the only test that studies have proven saves lives. There isn't yet any other test for breast cancer that has been tested over time to confirm that particular outcome. And another piece of information that is very important for the audience is the fact that the world in general believes that a mammogram is the end of the story, and that is absolutely not true. A mammogram is not 100% accurate, which means that a lady that has a mammogram has to have also a breast exam. So they have to have both, regardless of the results of the mammogram, which can be completely negative. In terms of the newer advances for breast mammography, we now have the three-dimensional mammogram, which is called 3D mammogram, and it has a fancy scientific name. But basically what that does is to allow us to detect lesions that are not quite as easy to see in a regular mammogram. And that requires a little bit of time before we can decide and prove whether it does save lives like mammography does.
So what I'm hearing you say is we know that it's very important. Women out there need to hear that story.
Exactly.
It's critical that women have breast exams, clinical breast exams, as well as a mammogram.
Exactly.
And I know there are standards for that, you know, when you're looking at diagnosis and treatment. And both of you, we have someone who deals with the surgical side as well as, you know, oncology, or the side if someone should have cancer. How often should women go for those type of examinations?
The discussion that has existed around mammography has to do with some of the guidelines that the United States Preventive Task Force came up with just in their last session. So what happens basically is that they said, well, patients do not have to have a mammogram until they hit age 50. We and most of the national organizations, the American College of Surgeons, the American Society of Clinical Oncology, the American College of Obstetricians and Gynecologists, everybody disagrees. And that is simply because the tradition has been that we start testing patients with mammography at age 40. Why do we think that it has to be maintained that way? Simply because over the last 34 years, we have seen a decrease in the mortality for breast cancer that did not exist before, and the largest decrease in mortality happened in the group of patients between 40 and 50. So we think that patients need to start at age 50 and they must have it once a year.
Very important.
Very important.
Now, Dr. Frame, I know that you deal with the side of this service when, you know, it's very scary. You know, women get the diagnosis, they have breast cancer. Can you talk a little bit with us about the treatment now, the options available to women? I think it is important that, you know, combining surgical and, you know, oncology treatment drugs, there's been a lot of advances and things have changed.
A lot of advances have indeed occurred over the years. And one thing that we have recognized as surgeons, as medical oncologists, as myself, and radiation oncologists who also are very much a part of the team, is that we're a multidisciplinary team, in that each of us bring unique elements of care and hope, you know, to patients in their journey. So someone may start with mammography or being followed up and have a diagnosis, and then that would lead to additional steps. And early on, both medical oncology physicians and radiation oncologists are involved to see where we best, you know, fit in that treatment that's best for that patient.
And I think you bring up a very important point, and that's the multidisciplinary approach. You know, as we've talked through this, it's clear that it isn't one particular physician or group, it's a group of physicians, and it really is individualized to the particular patient. And going to and getting that sort of holistic approach, I think, is critical. And I know that CAMC has done a lot with their Cancer Center and Women's Center. Can you speak to that just a little bit, either one of you?
Jim, you want to?
Well, the CAMC Cancer Center, we're very proud of. We've had groundbreaking for that in May of this year. And it's an emphasis of our healthcare system, our community, and healthcare providers to be able to bring a center together that is more central and has all the key elements together to make the experience for the patient from diagnosis through treatment more personalized for them, more convenient for them. And I think that that approach has been very instrumental. Dr. Kusminsky could speak to the incorporation of our breast care center and genetics counselor, and we also have tumor registry, clinical trials research, and radiation oncology. So we're increasingly building this family together that focuses on the health of our community and also in women's health, and we anticipate further growth in further multidisciplinary disease-based clinics where we can even provide more integration in care earlier for those we serve.
That is actually very much a piece of information that is important, but if you focus, for instance, on the breast center, I think that the concept that people need to perhaps understand is that the breast center or the cancer center is not a place. The breast center and the cancer center basically are a system which has changed the way in which we take care of patients. So what Dr. Frame was mentioning applies to any kind of cancer and certainly to breast cancer. But if you think in terms of what is the traditional way of doing things, the patient had a problem with the breast, they made an appointment to see their doctor, the doctor made an appointment for the lady to see the surgeon, then the patient was scheduled for a biopsy, then the patient gets scheduled to come back and have results, and then the patient gets scheduled to have surgery, and on and on and on and on. That has virtually disappeared with the system, because what Dr. Frame just explained is exactly the way in which the system has changed. A patient walks into the breast center or the cancer center, and everything from the very beginning to the very end is done right then and there in a very, very compressed period of time. So when you're talking about a situation that lasted many weeks in the past, now we're talking about something that can be compressed in 1 or 2 weeks, which makes a difference psychologically.
Oh, there's no question. I mean, I'm female. I mean, I recognize that. I mean, it's a scary thing.
Absolutely.
You know, you go in and you get a clinical breast exam, and then the physician says, send you for your mammography, and then someone says there's something there.
Right.
And then we know from there it is important that you get treatment an evaluation maybe and treatment quickly. And I know that we're doing some great things with treatment. We have new drugs for
Yes.
oncology for breast cancer patients, something that's been recent, Dr. Frame?
Yes, we've had a tradition of treating breast cancer for a number of years. Chemotherapy is sort of the more common treatment that people think about, but even that has evolved since the late 1970s when it was first utilized in women. This disease may have spread from the breast to the lymph nodes or other part of the body. It was at a time where treatment might last 6 months, and eventually over time we got those treatments sort of pared down to 6 months, sometimes less. Then we had treatments that came along that would either supplement or be used instead of chemotherapy. And we call those hormone treatments that block particular signaling pathways that send message to the governing body of the cell, the nucleus. But in this current area, we are learning a lot more about the genetic information, things that drive cancer cells, and that is allowing us to have new methods of treating patients. You'll hear terms like personalized medicine or precision-based medicine, and what that's referring to are very unique signals that may be within breast tumors or other tumors that we can directly address. So, for example, one of the more common ones is called HER2, human epidermal receptor 2, we call it HER2, and 25 to 35% of women have that chemical docking station on the outside of the cell overexpressed, and that sort of leads to hyperstimulation of the tumor. We have a treatment that can block that particular receptor to reduce signaling, but recently there's a newer medicine that works along with this HER2 pathway blocker that tries to further downregulate the signal and have further responses. And this has been impacting women with advanced disease that left the breast or earlier in the breast. Newer treatments that are now directed at controlling the cell cycle growth. And we'll be hearing a lot more about these drugs moving forward.
That's very exciting. I mean, when you think about what's been done, the research, and how we've been able to evolve, surgery is still indicated in many cases.
Surgery is indicated, but as Dr. Frame just said, basically the evolution of the care of patients with any cancer, but in this case breast cancer, has been very interesting, because what we have seen is that the structured treatment of breast cancer started in approximately 1892. So for the first 90 or 100 years, the treatments were changing because a single piece was being added to the whole. Well, in the last 10 years, the changes have been so fast-paced that now we are seeing things happening simultaneously, and some of the things that are happening are very exciting. But the most important piece is the fact that it is clear that the treatment of breast cancer requires a multidisciplinary team. There was a time when we did things single-handed. The surgeon was the one in charge of taking care of the patient with breast cancer. That is no longer the case.
Now we work together.
Now we work together.
We work together. We're colleagues very much. But,
Thank you.
You know, Dr. Kusminsky may not want to mention this, but he was very much involved being a leader worldwide, trained the trainer in new techniques of evaluating lymph nodes in the armpit area after a diagnosis of breast cancer. It's called sentinel lymph node biopsy. And I can say that that's made a tremendous difference in the patients that I've had the privilege to care for in terms of lymphedema or swelling of the arm, recovery time and healing, and also finding the answer out in a very focused kind of way without having to do some of the larger surgical excisions. And so I find in my patients now much less lymphedema or swelling in the arm, complications less, and I think that's a wonderful thing for our patients.
I think that what we've said here today is good news. And the good news is that we have better treatments. The key is early detection still. early detection. And we appreciate the work that both of you all do. And I thank you both for being on our program. This is very, very important to us. Dr. Frame, Dr. Kusminsky, thank you for what you do, and thank you for helping us today learn a little bit more about breast cancer awareness.
Thank you
It's
for
an honor.
having
Thank you
us.
very much.
Thank you.
Thank you.
Coming up, imagine having to battle breast cancer twice in your life. We'll meet someone who faced those challenges and learn what she has to say about overcoming those challenges. Stay with us.